And I'm going to share my PowerPoint. Again, hopefully you could all see the big PowerPoint full screen, yeah? All right. So based on some requests, what I think we'll talk about today is going to be a review of some basic thyroid pathology, including FNA as well as histology. We're going to talk about updates in some various concepts in thyroid pathology, thyroid cancer pathology most specifically, as well as emphasize the molecular testing that can be done both on fine needle aspiration as well as permanent surgical resection specimens. So, please feel free if you guys have questions to speak up or type it into the chat. I'll try to answer whatever questions might come up during the course of the lecture. So, essentially, we'll review the workup of thyroid nodules, which I think you are more familiar with than me as clinical specialists. We'll review the cytologic features of thyroid FNA and the corresponding histologic diagnoses. We'll identify those commercially available molecular tests that are available for thyroid FNA and understand their utility in guiding surgical management or not. We will discuss ramifications and changes in nomenclature, specifically with a focus on NIFT-P, non-invasive follicular thyroid neoplasm with papillary-like features. Since this is a relatively newer entity, I want to spend a little bit of time talking about what this means. And then we will demonstrate again the utility of molecular testing on thyroid resection specimens in order to guide either diagnosis, treatment, or prognosis. Just to remind ourselves, the thyroid develops as a condensation of endoderm at the base of tongue, migrates down the anterior neck, and then solidifies into the right and left lobes. Remember, the C cells are migratory, developed from neural crest, and so they migrate into the thyroid in their final resting place from their origins as circulatory neural crest. Because of that pathway of descent of the thyroid, of course, we know that there can be ectopias, either too high or too low, specifically things like pyramidal lobes or descending down into the substernal area. We certainly know about the possibility of the thyroglossal duct being persistent and cystically dilating, i.e. thyroglossal duct cyst. In general, we know that thyroid nodules happen in about 50% or more of the general population, being either benign or malignant, as you well know, identified either by the patient himself, by the doctor, or certainly based on neck imaging for other reasons, that being ultrasound, CT, MRI, in patients who are getting scanned for other reasons. When a thyroid nodule is determined to be suspicious enough for further workup, of course, ultrasonographic examination followed by fine needle aspiration biopsy is standard of care. In general, ultrasound guidance is preferred over palpation because, as you know, many of these patients have multiple nodules. Ultrasound is certainly going to target the one of interest, make sure we are in the nodule of interest, and make sure that we have sampled within that nodule. In this institution, most of the ultrasounds are done in radiology with cytopathologists determining the adequacy of the sample, but of course, some of the clinical offices do the aspirations with their own ultrasound without a cytopathologist to determine adequacy. All right, so I grabbed this figure from the ATA, from the American Thyroid Association Management for Guidelines of Thyroid Nodules, basically just reminding us what the ultrasonographic features are of benign, low suspicion, all the way to high suspicion, of course, being things like microcalcifications, irregular margins. You, again, are more adept at visualizing these, I'm sure, than I am, because I don't really see the ultrasound, I see the pathology. However, based on the ultrasonographic features, the need for fine needle aspiration biopsy is then determined. So high suspicion index certainly will prompt a fine needle aspiration. Then the cytologic features on FNA will help determine the need for surgery. And then the histologic features upon resection determine the final diagnosis. In general, the goal of preoperative FNA is to differentiate benign from malignant, certainly to guide therapy, where a benign asymptomatic person can undergo observation, a benign symptomatic person resection, and certainly a malignant diagnosis resection. However, not all FNAs are obviously benign or obviously malignant, and this is where we come to the Bethesda system. So the Bethesda system sorts FNA findings into categories with increasing risks of malignancy upon final surgical resection. Unsatisfactory, or Bethesda category 1, is essentially we didn't really get many cells, repeat. A Bethesda category 2 is the cytologic features are consistent with a benign nodule. Bethesda categories 5 and 6 are either highly suspicious or suspicious for malignancy, such that surgical resection essentially will be performed either as a lobectomy or a total, depending on other clinical circumstances. And it's the categories in the middle, the 3, the AUS FLUS, and the 4, the follicular neoplasm, that are considered indeterminate with wider ranges of resulting malignancies on surgical resection. So the Bethesda category estimated rates of malignancy for each of these categories is listed on this column on the left. Our actual rates of malignancy with these Bethesda categories from our institution is listed on the right. On the right, you can see very low rates of any malignancy being identified in something we call benign, very high rates of anything we call malignant, almost 100%, ranging all the way from 16 to 25 for follicular neoplasm to 79% malignancy in the 3, 4, and 5 categories. I will point out, and I'll show you examples of the differences that we diagnose, at least at U of C, between AUS, atypia of undetermined significance, and FLUS, follicular lesion of undetermined significance, whereby AUS is considered more of a finding of nuclear atypia, where you are actually more concerned for papillary carcinoma, and FLUS, follicular lesion of undetermined significance, is a architectural atypia, meaning small follicles but bland nuclei, where you're actually more concerned for a follicular neoplasm like a follicular adenoma or follicular carcinoma. So we will go over the various categories ranging from benign to indeterminate to malignant in the next slides. So if you guys don't mind, I'm going to have you participate in some polls for what you think might be the most likely Bethesda category. I'm not going to test you on non-diagnostic, but we will go through the others. So this is an example of a patient who has a sheet of bland follicular cells, almost like a sort of very evenly organized bricks. And then in the background, we see this watery material in the background, which is colloid, and another scant string of cells. So can you see the poll, and does anybody want to volunteer their guesses? It's anonymous as to what most likely Bethesda category this falls into. All right. 4 of 5 voted. I will take it. So it's a very wide range of answers, from benign to nuclear atypia to architectural atypia to follicular neoplasm. Nobody thought this was suspicious for carcinoma, so well done. I will tell you that the correct answer in this case is going to actually be benign colloid nodules. So let's think about why these histologic features or these cytologic features are reminiscent of a benign nodule. So if you think about nodules in the thyroid, they architecturally are composed of usually either follicles or papillae if it's, if we're thinking about papillary carcinoma. And the follicles can either be very large or very small. And so if you tore a chunk off of a large follicle, it might end up like a sheet, right? If you're aspirating very small follicles with little colloid, you're probably going to end up with little small rosette-like structures, which we'll see in the future. So these large sheets and just swaths and swaths of colloid implies large follicles. So what does that look like on histology? So this would be the histologic correlate of that benign colloid nodule, where you can see the follicles are very, very large. And if you scrape the chunk of this off, it would be just a sheet of cells with very bland nuclei, and you'd see lots of colloid because you've sort of aspirated out of this nodule. So this is a very well circumscribed lesion that is composed of large follicles, or sometimes called macro follicles. And the nuclei are small, round, dark, and regular. So we're not thinking about something like papillary. So this, in fact, is a colloid nodule. Some might call it nodular hyperplasia. Some might call it macrofollicular adenomatous nodule. These are all benign terminology that probably corresponds to colloid nodule on FNA. All right. The next one is a cluster of cells here that is a smaller cluster. However, the nuclei are still relatively round and regular. The cytoplasm is perhaps a little more abundant and granular, and there are these very small lymphocytes in the background. So these large cells, I will tell you, are trying to be oncocytic in morphology, and these smaller cells are lymphocytes in the background. So when you see hybrid of oncocytes and abundant lymphocytes, what might this make you think of? Does it make you necessarily think that it is a solitary lesion? Does it make you think that this could be a diffuse process? So often this is the characteristic appearance of lymphocytic thyroiditis. So sometimes in Hashimoto's or in processes that diffusely involve the thyroid gland by inflammation, there can be some evidence of nodularity throughout, and the dominant nodule might be targeted. However, this combination of oncocytic change and lymphocytic thyroiditis is quite suggestive of just a Hashimoto's benign rather than an actual lesion. So taking everything into consideration, especially if this is a multinodular thyroid or a patient with known Hashimoto's, we may be sampling one of these dominant nodules in Hashimoto's. So these have nodular cut surfaces, tons of chronic inflammation seen here in blue with germinal centers, and the follicles undergo so-called oncocytic change in response to the inflammation. If you were to have a true oncocytic follicular neoplasm, you may not expect so many lymphocytes, because usually in follicular neoplasms, usually the lymphocytes are excluded if it's a true tumor, usually. So the presence of lymphocytes kind of suggests a diffuse inflammatory process, and we come to the diagnosis of Hashimoto's thyroiditis. So I will show you here. First of all, what are oncocytes? What does that mean when we say oncocytes? So in the thyroid, as you know, oncocytes are referred to often as Hürthle cells. Usually they are a metaplastic change, meaning a response to injury in a number of various organs, including thyroid, parathyroid, kidney, salivary glands. So you can see an oncocyte in any of these organs. Of course, in the thyroid, they're referred to as Hürthle. But in all of these organs, they are composed of cells with abundant eosinophilic granular cytoplasm. Granular because they are full of small little speckles of mitochondria, as you can see on these electron microscopic images. So here's the nucleus, and here's the nucleus, and these oblong structures are all the mitochondria. They also have large nuclei with prominent nucleoli, So those are the features of oncocytes on cut section, and we saw them before on the FNA. Remember, you can also get an oncocytic or a Hürthle cell neoplasm, but again, that would usually exclude the inflammation. All right, so the next specimen is, most of the specimen is composed of these bland kind of sheets, again, that look like very regular bricks in a row. And we've already identified this as being the one on the left as being most likely in a benign nodule. However, on occasion, you see these clusters of cells that are more disorganized, and they have very wrinkled nuclei, irregular contours, sometimes nucleoli that stand out. So one person has voted and has correctly said AUS nuclear atypia. So this is an example of a specimen where nuclear atypia is present, but it's quite focal and somewhat minimal. Therefore, we're not ready to call this malignant papillary carcinoma yet. However, there are these nuclear features that are starting to resemble it. This is in contrast to the next case, which is, rather than a cluster, it's actually forming this small rosette or this small microfollicle. In the center of this microfollicle, if you're lucky, you may find colloid, and you may not, as in this case. But if you look at the nuclei, they're all very round and regular. And in fact, yes, the voter said FLUS architectural atypia, which is correct. So while the nuclear atypia is going to suggest you more of potential papillary, the architectural atypia is going to suggest you more for a follicular neoplasm. All right, now moving on to the next case, which, unlike the prior, is very cellular. So this has sheets and clusters of thyroid cells, sometimes interspersed individual cells. There are these strips, as I'm trying to point out here, of capillaries, and then again, these clusters of cells. However, the nuclei are still round and regular, and I don't see grooves or inclusions. So when it's a specimen that is this cellular, we start to raise up in our Bethesda category. And so the likely answer here is actually going to be follicular neoplasm. And the only, the best difference between a FLUS microfollicles and a follicular neoplasm with microfollicles or clusters is the amount of cells. It's just the amount of cells present on the slide. In this case, there are very many more cells. However, because the nuclei are still round and regular, we're not going to give them an architectural atypia, but we're going to give them a follicular neoplasm status. So this, in fact, is a Bethesda category 4 follicular neoplasm. This might correspond to an actual resection of a follicular adenoma, or in fact a follicular carcinoma. And so you can see how the histology recapitulates that high cellularity with very little colloid. So unlike the benign nodule that had lots of colloid and large sheets of cells, right, this has very little colloid and very round clusters of cells that are very cellular. So that you can match the cytology to the histology here. Again, this is well circumscribed. In this case, there is a fibrous capsule, and within the fibrous capsule are these clusters of follicles with round, bland nuclei. So this, in fact, is a follicular adenoma. These usually correspond to FLUS or even follicular neoplasm on FNA. But of course, as you know, the main reason to differentiate between or the main need is to differentiate between follicular adenoma and follicular carcinoma. Follicular carcinoma, as we will see, being defined by invasion through the capsule, capsular invasion, usually in the shape of a mushroom, so that's kind of a nice pictorial to remember, or vascular invasion into blood vessels either in the capsule or in the periphery of the nodule. So the only difference between adenoma and carcinoma is in that invasion through the capsule or into blood vessels, neither of which we can see on FNA, right? So follicular neoplasm could imply either of these diagnoses, hence essentially the need for resection for definitive diagnosis. Here's a closer example of that vascular invasion, where you have endothelialization of a tumor thrombus and adherence to the wall, perhaps with fibrin thrombi. This is true endothelial disruption, true vascular invasion. These are really not lymphatic vessels. These are, in fact, blood vessels, usually venous caliber, hence the propensity of follicular carcinomas to travel hematogenously to visceral sites like lung, brain, bone, etc., as opposed to papillary, which we will talk about, that tends to invade lymphatic vessels and travel to lymph nodes. All right. So our next FNA are very cellular clusters, again, of those oncocytes. Here's how we tell oncocytes. So in the panel on the left, the cells are quite large, and you can vaguely make out perhaps how the cytoplasm has a little bit of granularity. So you can see that cytoplasmic granularity on FNA as well. You can certainly see these large nuclei with very prominent nucleoli, as I'm pointing out here with my arrow. So hopefully you can make out the features of oncocytes. Again, on the right, sometimes the nuclear features are a little bit less clear, but you can see the abundant cytoplasm. I will remind you, I don't think I talked about this on any of the others, but just as a reminder, there are two main stains that we use on FNA. One is the Diff-Quick, and one is the PAP. And so the one on the right is the Diff-Quick stain, and that's what is used during rapid on-site evaluation. It's quick, literally, because you can stain the cells very quickly. The benefit of Diff-Quick is not only its quick ability to stain, but the fact that you can very nicely make out the density of the cytoplasm. Unfortunately, the nuclear features sometimes get lost in the Diff-Quick. However, the PAP stain, which requires longer-term processing, overnight fixation, and staining, the nuclear features end up being a little more clear. So we use both the Diff-Quick and the PAP in conjunction to tell the characteristics of the cytoplasm and the nucleus, which may manifest differently on the two stains. So the PAP is a better nuclear stain. Again, you can see that just based on the fact that you can see very nicely these prominent nucleoli, whereas in the other one that was a little more difficult. So just a reminder of the PAP versus the Diff-Quick. And your results were either follicular neoplasm or suspicious for carcinoma. And so because we are dealing with oncocytes, the nuclear characteristics of oncocytes are allowed to be a little more irregular before we start worrying about carcinoma, simply because oncocyte nuclei can be a little more atypical than our regular follicular cells. Therefore, if we have the background cytoplasm and the background morphology of an oncocyte, we don't want to rush to thinking about it being cancer simply because of the nuclear irregularities, because they are allowed in oncocytes. Therefore, this is going to be a 4 Hürthle cell neoplasm. So whoever said follicular neoplasm, that is in fact the correct answer, because Hürthle cell neoplasm falls under follicular neoplasm. Okay. Does anybody have questions or comments? All right, this is an example of that Hürthle cell adenoma on resection. You can see that it has a well-defined edge, perhaps not a true capsule, but at least a well-defined border. And you can see these very densely packed clusters of oncocytes with large nuclei, prominent nucleoli, pink cytoplasm, no inflammation, right? So this ended up being a Hürthle cell adenoma. Same concept. You can only distinguish adenoma from carcinoma by capsular or vascular invasion. Okay, moving on to a highly cellular specimen with these kind of branching or staghorn structures, sheets of cells with very dense cytoplasm, wrinkled nuclei. And on the next slide, we're going to see the most characteristic feature, I think hopefully you guys can appreciate, these intranuclear cytoplasmic pseudoinclusions here and here, being the cytoplasm that's invaginated into the nucleus. And when you look at it, it almost looks like a hole in the nucleus. Exactly. So this, in fact, is carcinoma or suspicious for carcinoma. These are the characteristic nuclear features of papillary that you specifically want to see. We'll talk about the nuclear features of papillary. So here's an example on low power on the top and higher power on the bottom of papillary, being an infiltrative neoplasm architecturally with both papillae and follicles. Papillae, as you know, are fibrovascular cores with epithelial cells lining them. So here's a papillum cut longitudinally. Here's a papillum cut in cross-section. And those nuclear features that we're looking for, both on cytology and surgical pathology, are nuclear enlargement, elongation, grooving, almost coffee bean shapes, certainly overlapping as seen here, and then those pseudo-inclusions as highlighted in these three right-hand panels. The next tumor I'm going to show you is slightly different, where the cells are a little bit more fusiform or elongated. You see granular cytoplasm. You see some very large nuclei and some smaller nuclei. And if you look carefully, you see this small extracellular material. This is actually amyloid. So these spindly cells with more wispy cytoplasm, I'll just tell you the answer here. This ends up being a medullary carcinoma. Medullary is one of those cancers that we can diagnose on FNA because of its characteristic cytomorphologic features. So medullary, you know, is your calcitonin secreting cancer of thyroid, calcitonin secreting cancer of thyroid that is derived from the C cell calcitonin secreting neuroendocrine cells of the thyroid. The C cell derived neoplasm, also, because this is also a neuroendocrine tumor, has neurosecretory granules in the cytoplasm. So it also has a purple granular cytoplasm. However, the nuclei here don't have those prominent nucleoli like we saw in the Hürthles, but they have very finely stippled or granular, or sometimes people say salt and pepper chromatin. That is characteristic of neuroendocrine neoplasms. So that's medullary. Lastly, we're going to talk about rarer cases where you see very solid groups or clusters of cells that are very dark hyperchromatic nuclei. You might see some highly pleomorphic cells, very large with very prominent red nucleoli. So this might make you worry about something beyond our normal, follicular, papillary, medullary. These might be cases that you might want to consider something else, like a poorly differentiated or an anaplastic thyroid carcinoma, like even sometimes metastases to the thyroid. So just to review, the aggressive thyroid carcinomas are considered poorly differentiated. The former name for poorly differentiated used to be insular carcinoma, so you might read this in the literature. And anaplastic or undifferentiated. Anaplastic or undifferentiated no longer resembles thyroid. On the left, the poorly differentiated becomes solid with mitoses and necrosis. On the right, the anaplastic no longer resembles thyroid, as I said. It can be very plump and epithelioid and pleomorphic. It can be spindled. It can be even resembling squamous cell carcinoma. Very bad prognosis, as you know. Does anybody have questions before I move on? So we're going to talk about the molecular mutations in thyroid cancers because these are going to be important for our understanding of the molecular on FNA and the molecular on resection. So both follicular adenomas and follicular carcinomas have overlapping genetics, meaning a predominance of RAS mutations, HN or KRAS, and or PAX8 gamma fusions. Those are the top two in follicular neoplasms. So when I say follicular neoplasm, I mean follicular adenoma or carcinoma generally. Papillary exclusively has BRAF V600E and RET PTC rearrangements. Both papillary and follicular can transform to poorly diff. Both can transform to undifferentiated or anaplastic, and poorly diff can also transform to undifferentiated or anaplastic. Once you start developing the higher grade poorly diff or undiff, you start to develop additional molecular events such as TP53 mutation or TERT promoter mutation, both of which may signal a more aggressive thyroid cancer. Medullary is in a box on its own. It tends to have RET mutations, both in the sporadic and the syndromic cancers. So finding a RET mutation in a medullary does not mean the patient has a syndrome. It means the tumor has a mutation. So you always want to test the peripheral blood in these patients if you can. Not every thyroid tumor, unfortunately, harbors a known mutation. In some cases, the genetic drivers remain unknown, but these are the most common ones we discuss. And this is how we can apply this knowledge to molecular testing on FNA. There are three major commercial tests for indeterminate cytology in the US. Indeterminate meaning generally Bethesda 3, 4, and sometimes 5. Those companies are Veracyte's Afirma, Interpace Thigenex and Thyromir, and ThyroSeq. All of them have a gene expression profile that sorts nodules into those with patterns more commonly seen in benign versus more commonly seen in malignant. So this is basically messenger or microRNA expression profile. The second component of these is specific single gene mutations or fusions like the ones we just mentioned that can be specific for various neoplasms. All right, so these two components are present in all of these molecular tests. What does that mean? So if your gene expression profile and your point mutation fusion profile is negative, this is highly predictive of a benign neoplasm, ranging anywhere in their citations from 4 to 5% risk of malignancy upon resection. So a negative result in a molecular test is very helpful to rule out malignancy and avoid surgery because you've taken an indeterminate nodule cytologically and you've put it in a molecularly benign category. However, a positive result is highly variable and depends on what you've identified, anywhere ranging from 50% to 99% risk of malignancy, depending on the specific finding that exists in that tumor. So what I always advise people while reading these molecular reports is not just to read the overview, positive or negative, but really read what they found, because this will give you a lot of information. And I will tell you what that means. So to recapitulate, if you have a benign result on FNA, you've taken that cytologically indeterminate nodule, risk ranging anywhere from 10 to 40%, to an effectively benign nodule, less than 5%. These patients can be observed clinically as appropriate. However, with a positive or suspicious or still yet indeterminate molecular result, generally these people will require diagnostic lobectomy. If you find a cancer-specific or a neoplasm-specific mutation, here's what it might look like. So when you read, what does positive mean? Positive for BRAF V600E or RET PTC, which we know are found exclusively in papillary, RET mutation, which is found exclusively in medullary. These are essentially specific for cancer. So this will tell you the patient pretty much has cancer, so that lobe needs to come out, at least the lobe, right? However, there are these other mutations that are not specific to cancer, but they are specific to follicular neoplasms, right? So that would be RAS, HRAS, NRAS, or KRAS, and things like PAX8 gamma. These are all mutations found in adenomas, follicular carcinomas, and even, as you will see, in our new entity NIFT-P, all right? So please read what's there, as it can give you highly specific information if one of these is found. The other one I will mention, as we said before, would be something like a P53 or a TERT promoter mutation, which have only rarely been described in benign things. So those should raise your suspicion for cancer as well, the P53 and or the TERT, okay? Does anybody have questions so far? So one of the things I discuss with the surgeons, probably less relevant for you guys, but I will just mention, the patient now goes for a thyroidectomy, either a lobe or a total. Do we perform intraoperative evaluation? And the answer, or frozen section, right? And the answer is essentially no. Frozen sections are strongly discouraged because in most cases, they do not change or add any additional information from the FNA. A follicular neoplasm will remain a follicular neoplasm. We're not going to diagnose follicular carcinoma on frozen. And a papillary carcinoma will stay a papillary carcinoma in most cases. So we advocate not doing frozens on thyroids. Some surgeons out there still request it, but it hasn't been shown in multiple studies in multiple institutions to actually add any information. So we discourage it. Once we do get the thyroid, we do fix it overnight before sectioning for a number of reasons, because the overnight formalin fixation process solidifies the thyroid, which can be very gelatinous and kind of gooey sometimes. It preserves that outer edge, that fibrous plane of the thyroid. And so when we cut through it, the sections are much more clean and organized without slippage of those planes. So we do advocate formalin fixation overnight for the thyroids. One thing I've been asking our grossers to do is to evaluate for the gross extent of extrathyroidal invasion, if present, specifically because of the new AJCC, well, not new anymore, but the 8th edition AJCC staging criteria. So in the past, in the 7th edition, any extrathyroidal extension, minimal into the fibroadipose tissue, resulted in an upstage to T3. Now the 8th edition criteria are much more stringent, saying only macroscopic, meaning right, grossly visible extrathyroidal extension into the skeletal muscle results in an upstage to T3. So if we see it microscopically just into the fatty plane, we will not upstage the patient. If we see it grossly into the skeletal muscle, or the surgeon finds it adherent to the skeletal muscle intraoperatively, this is the criteria for upstaging to a 3B. So just as a reminder, the major change, at least for extrathyroidal invasion in the 8th edition system. So here's a microscopic example of what extrathyroidal extension might look like. You see a very kind of ragged border at the edge, and upon closer inspection, we see small follicles of tumor invading into this background skeletal muscle, the skeletal muscle being these pink bands, all right? So we always want to correlate our microscopic impression of extrathyroidal invasion to the operative report or the surgical impression to know if it correlates with gross ETE. Okay. The other thing I will mention is calcification in thyroid nodules. As you know, neoplasms can either have this peripheral coarse eggshell calcification in the capsule or internal microcalcification, which would be more signifying of papillary carcinoma, right? So fine microcalcifications, papillary, eggshell calcifications, less specific for papillary. Certainly, we sometimes get thyroid cancers that are actually metastatic to bone. All of these tissues, if they have calcifications in them, need to be decalcified. And so we take special precautions in the gross room to process these tissues differently with gentle decalcifiers to preserve the nucleic acids. So if you ever have a patient that has a highly calcified lesion that has a metastasis to bone, and you think that next generation sequencing for DNA mutations or RNA fusions is going to be necessary for your clinical practice, alert us, alert the gross room, alert the pathologist, because we will need to process these slightly differently than our routine decalcifying solutions. Specifically, we would be using a gentle decalcifier like EDTA to preserve the integrity of the nucleic acids. Very important in today's era of personalized medicine. All right, so just, you know, keep that in the back of your mind if you ever have a bony biopsy on a thyroid cancer or other cancer patient. Okay, we occasionally we'll need molecular testing on these core biopsies of metastases or on the thyroidectomies, sometimes for diagnosis, sometimes for prognosis, and certainly sometimes for treatment with the BRAF or the NTRK inhibitors. I'm going to talk a little bit in the last 15 or so minutes about the implications of molecular testing for these three areas. A lot of the knowledge we have on molecular and thyroid came from the TCGA paper back in, when was this? 2014, where they took all papillary carcinomas and ended up defining them into these BRAF V600E like true papillary carcinomas and these RAS like so-called follicular neoplasms. And these are genetically mutually exclusive, and then they can be sorted into these, two groups. This will become important when we talk about NIFT-P specifically. So historically, thyroid cancers were classified on their histology, being just, did they grow in papillae, did they grow in follicles, or did they grow mixed, okay? They were also sorted by behavior. Were they well differentiated essentially? Were they more aggressive? Or were they very bad and anaplastic? So very similar to what we have today. What I will talk about for a minute is this development of the so-called follicular variant of papillary that came about in the 60s and 70s that were invasive neoplasms with those characteristic papillary-like or ground glass nuclei. They behaved like papillary carcinoma, but they just happened to grow in follicles instead of papillae. And so the follicular variant of papillary was born. These had lymphatic metastases, these had invasive growth just like PTCs, they just happened to grow in follicles. So rather than calling them follicular carcinoma, right, which was a pattern-based diagnosis, this was more of a behavioral diagnosis, and they called it follicular variant of papillary carcinoma. Does that make sense? So they said, this is biologically looking like papillary, even though it's growing in follicles, I want to call it papillary. Okay. So then some encapsulated tumors that were growing in follicles, some had capsular and vascular invasion, all of them had papillary carcinoma-like nuclei, were sometimes shown to metastasize to lung and to bone. So then the nuclear features started to take precedence over the architectural features and the behavioral growth patterns. So then any tumor growing in follicles, either encapsulated or invasive with papillary nuclei, was called papillary carcinoma. So regardless of growth pattern, the only thing that was used to diagnose papillary eventually became nuclei. All right, so we're left with follicular adenoma, or follicular neoplasm that has follicles, very bland nuclei, lacking invasion. We have follicular carcinoma, which has follicles, which has bland nuclei, but has capsular or vascular invasion, right? We have papillary carcinoma, which sometimes grows in papillae, sometimes in follicles, sometimes a hybrid, certainly has morphologically atypical nuclei, and certainly has invasion. But then we are left with the follicular variant of papillary carcinoma that grows in follicles, that has atypical nuclei, but invasion was not necessary for diagnosis, only nuclear features. So this is the only outlier. This is really the only tumor we could call carcinoma without invasion, which just seems weird. And so we have regrouped from that not historic, it's only a few years ago where we've changed our thinking, but we have rethought this process. So the infiltrative papillary carcinoma that actually has invasion is still papillary carcinoma. But what do we do with this well-circumscribed so-called encapsulated follicular variants of papillary that is really 100% follicles and just has those funny-looking nuclei? Well, it was found that these groups were the ones that sorted differently between the BRAF V600E-like and the RAS-like, okay? Where the infiltrative carcinomas had the BRAF V600E and the lymph node metastases, and the encapsulated non-invasive carcinomas had RAS mutations and really only had metastasis if they had vascular or capsular invasion. This is very similar to our classic concepts of classic PTC and classic follicular neoplasms, i.e. adenoma carcinoma. Okay, so we're beginning to sort these things back out genetically as opposed to lumping them from their nuclei. All right, so in 2016, this proposal came about for renaming the non-invasive, well-circumscribed follicular variant of papillary thyroid carcinoma to NIFT-P if it met certain criteria, right? NIFT-P being non-invasive follicular thyroid neoplasm, so neither benign nor malignant, just neoplasm with papillary-like nuclear features if certain criteria are met. I won't belabor the criteria with you, but they are listed here if you'd like to review them. So in 2018, we came down with a revised system that essentially did not allow any papillae, certainly did not allow any invasion, and did not allow any BRAF V600E mutation, because we know that is incompatible. Those are mutually exclusive. All right, so when you talk about the BRAF-like and the RAS-like. All right, so the proposed terminology was based on the combination of genetics, morphology, and behavior, where we now are no longer calling non-invasive encapsulated follicular variant of PTC. We're now calling NIFT-P, okay? The nuclear features now exist across the board, right? Nuclear features we've now realized are less important than the architecture and the genetics. So NIFT-P is important because in the past, a diagnosis of follicular variant of papillary may have prompted completion thyroidectomy and radioiodine, especially depending on large size, patient clinician preferences. However, a diagnosis of NIFT-P, you're done. Just observation for the time being. Does not require completion, does not require radioiodine, because the rates of metastasis in these is essentially nil if there is no capsular or vascular invasion, right? If there is capsular or vascular invasion, then it's a carcinoma, don't worry, all right? But these are the ones that are non-invasive, as the name suggests, right? They can be observed. So from our follicular variant of PTC that was separated into two groups, the infiltrative and the encapsulated, we have true follicular variant of papillary that resembles classic papillary. And we have this now new NIFT-P neoplasm that very much resembles, I think, a follicular adenoma that's circumscribed, that has a RAS mutation. The only difference is in the nuclei. There's also the invasive, right, counterpart of NIFT-P, which some people are starting to call follicular carcinoma with, nuclear atypia. Many people still refer to it as the invasive encapsulated follicular variant of papillary. I know the terminology is a little bit confusing, but I like to think about it as being, we can draw a very clean line with genetics, with the RAS-like and the BRAF V600E-like, even though these nuclear findings reside on both sides of that line. So I like to think about everything on the right of that line as being essentially a follicular neoplasm that in its biology is resembling a follicular adenoma and a carcinoma. And anything to the left of that line as being a papillary carcinoma neoplasm that resembles in its biology a classic papillary carcinoma. I hope that makes sense, because these terms are used differently by different pathologists, and I think it's important for us to understand how the morphology and the genetics can be used but can be confusing, and so we really have to think on all levels about these cases. Does anybody have questions or comments? All right, so molecular testing can help us on a resection thyroid if we find something like an HN or KRAS mutation that would argue for a follicular neoplasm, whether it be adenoma, carcinoma, or NIFT-P, right? It argues against papillary. If we find a BRAF V600E or V600E-like profile, this will certainly argue for a papillary carcinoma. And here's an example of why this can be clinically important. A female has two tumors, one on the right, one on the left. The one on the left is a classic papillary carcinoma with stromal sclerosis, invasion, intranuclear inclusions. The one on the right is larger, 5 centimeters, but very well circumscribed, composed entirely of follicles, but has these very irregular, crowded, wrinkled groove nuclei. Well, you know, if both are papillary, this is a 1.4 and a 5 centimeter PTC. This is now a PT3A. If only the smaller one is a papillary, this is a T1B, perhaps resulting in different treatment for this patient. So we found BRAF on the classic papillary, BRAF V600E, and an NRAS on the opposite lobe. So this was supportive of the 5 centimeter tumor being a follicular neoplasm that would not require any additional treatment, that would not require staging or treatment like a cancer. So this patient got the T1B diagnosis, no lymph nodes were positive, really no need for radioactive iodine in this patient. Okay. Another method we could test for that BRAF mutation, if not molecular sequencing, is immunohistochemistry. So there's now a specific antibody for the BRAF V600E mutant protein that is highly predictive of the mutation being present on sequencing. So we use this here in our institution. I will go very briefly over BRAF V600E, it being a cytoplasmic signal transduction protein, hence we can detect it in the cytoplasm with that specific V600E epitope targeted. We know that sometimes the BRAF V600E mutated cancers can be less likely to uptake radioactive iodine and may develop radioiodine resistance, or may on the get-go be radioiodine resistant. However, they can certainly respond to targeted therapies against BRAF V600E. So those being vemurafenib and dabrafenib most commonly, small molecule inhibitors against the V600E mutant protein. I'm sure you as treating physicians could tell me more about this than I could tell you. But it essentially competes for the binding site on the BRAF kinase and inhibits its ability to function in signal cascade. This is highly selective for BRAF V600E mutant cells. Any other mutation of BRAF or any other fusion or rearrangement of BRAF is not effective, okay? So it's specifically the V600E mutant. Clinical trials for use in differentiated cancers certainly are out there, but more often, I assume it will be used more prominently in the more aggressive or undifferentiated cancers that are having trouble responding to other standard therapies. I mentioned TERT promoter earlier, so I want to just mention it at the end before our time is up, because I do think this is important. TERT promoter mutation can either be found in isolation or concurrently with BRAF or RAS. If it's found in synergy or concurrently with BRAF or RAS, it is thought to be even worse than if found in isolation. So to remind us, telomeres are those repeats at the end of chromosomes that shorten with each cell cycle that appear to cause cellular senescence or aging after a certain number of cell divisions. However, TERT, telomerase reverse transcriptase, basically adds those caps back onto the ends of the chromosomes to basically protect the DNA from aging or senescence, right? So TERT telomerase is active normally in germ cells and stem cells because we want those to live for a long time, but it goes away in our differentiated somatic cells. However, it's reactivated in a lot of cancers. Normally, when the telomeres are gone, the cell senses broken DNA and pushes the cell into senescence. However, if the telomerase adds those telomeres back on, this is effectively resisting cellular senescence. And this is what happens in cancers that have TERT promoter mutations. They start adding those telomeres back on. They are survivors. They are the survivors of the cancer cells. So this tends to be mutations, as I said, in the promoter region of the TERT genes, such that much more TERT is transcribed than normal. So the TERT itself is not mutated, it's much more actively transcribed because of the promoter being mutated, okay? So as I said, TERT promoter mutation alone is thought to be associated with worse prognosis, and it's found in approximately this percentage of papillaries, folliculars, poorly diffs, as you can see here. But combined with either BRAF or RAS, it's again thought to be synergistic and predict effectively the highest risk of recurrence and mortality compared to it being found in isolation. Prevalence of TERT and BRAF combined in PTC is anywhere between 5 to 8%. Prevalence of TERT alone in PTC is a little bit higher, 10 to 12%. All right. So that's what we know about TERT and why we are so cautious about it, because it could be such a bad prognostic indicator. The other targetable mutation or rearrangement in this case in thyroid cancer is NTRK. So 1, 2, or 3 generally. These are transmembrane proteins that again drive intracellular signaling, and they are most commonly altered by gene fusion, such that the chimeric oncoprotein, whether it be ETV6 NTRK or BCAN NTRK or whatever other partner NTRK, this fusion protein generates a constitutively active kinase driving the cell through the cell cycle, of course. Therefore, these NTRK inhibitor drugs have been shown to have various levels of efficacy against the various fused forms of TRK. Most commonly, we see entrectinib and larotrectinib as the first generation NTRK inhibitors. Hence, in our fusion panel here at the U of C, we are testing for NTRK fusions. A very small percentage of thyroid cancers have it, but if it's present, it's actionable. So hence why we look for it. In the last couple minutes, I will say thank you for your attention, and if you have any questions or comments, you can either send them to me now, feel free to email me if you have anything followed up in the future, but I hope this was educational for you. Thank you.
Thank you. It was great. Thanks a lot.
You're welcome. Would you want to have access to the slides or the recording, or
if possible, yes, would be great.
Yes.
Okay.
I really wish we got this lecture at the beginning of our fellowship. It's very informative.
Okay, good. Well,
and still, you close so many gaps. Thank you so much.
Oh, you're welcome.
Mm-hmm. Awesome. Yeah, how can we access the recording? Would it be emailed to us? Or?
So you know what I'm going to do? I have been putting them up on YouTube as private or as unlisted. So I will just send you the link to the video, and as long as you have the link, you can view the video, and I can just send you like a PDF of the slides.
Yes, that will be awesome. Thank you so much.
Of course.
Okay, take care. Bye.
Mm-hmm.